All right. Dr. Amjad, of course, you're here.
Yes.
Colonel Cahill. No. Joe Deegan.
Here.
Dr. Khan.
Yes.
Jesse Forbes, we know he's not going to be here. He has court. Dr. Malil. Dr. Barry.
Present.
Sean Hammers, he's also in court, won't be here. Rusty.
Here.
Dr. Antolini.
Present.
Dr. Milton, got pre-notice he would not be here. Joe Hatton. JJ Barnaby.
Here.
Okay. 1, 2, 3, 4. 5, 6, 7. All right, Dr. Amjad, that's 7 members. With the vacancies, that would be a majority. So we do appear to have a quorum.
Okay, great. Thanks, Jason. So we need to do a review and approval of our previous minutes.
Yes, the minutes were sent out to the members for review, and we do need to take a vote to approve the minutes.
I move to approve.
A second.
Second.
And then we also sent out the public comments. I don't know if anyone had a chance to look at those. It was just a couple of pages. That was in the email or the invite as well. We need to go over those, Jason, or talk about any of those.
So only if there's discussion from the members on those public comment. No discussion
Anyone?
from any members? All right. I think we can move on from that, Dr. Amjad.
And the second is, I guess, are you going to go over your slides now?
Yes.
All right, thanks.
So first, I want to start with an update from the Office of Medical Cannabis. Right now, we have approximately 3,500 patient applications received. We continue to process those. We've been able to reduce the amount of time it takes to process a patient application within the recent weeks. We're down to about 30 days. Previously, we were up to 60 to 90 days to process patient applications just due to the volume that is coming in. So through adding more staff and streamlining that process, we have greatly reduced the amount of time patients have to wait for their card to be approved or for them to revise their application as needed. On the industry side, we have 3 operational growers in the state at this point. We also have an operational processor. Each of those operational growers is a vertically integrated organization. So we expect those other 2 integrated processor licenses to come online within the next couple months. There should not be any issue with being able to process their products within their respective organizations. Of course, the next step after that will be for their respective dispensaries to come online and any other third-party dispensaries that they partner with to retail their products. So industry continues to progress. We still expect the first products, medical cannabis products, to be on sale in West Virginia in mid-November, barring any unforeseen difficulties. Right now in the state, there are approximately 3,000 legal medical cannabis plants growing at various stages of development, with about 1,000 of that group in the final flowering stage prior to harvest. One point to make is, again, because this is an all indoor grow operation, there will be basically a continuous harvest once we get to that final stage for these plants. So each week there will be more and more mature plants available for harvest. And we also expect that overall number of available plants to continue to expand as industry builds out and matures within the state. The Office of Medical Cannabis continues its public information campaign by social media, written media, and also radio and TV to make potential patients aware of the new medical cannabis program that exists in West Virginia. And we also continue to have in-person sign-up events for potential patients that may have difficulty navigating the online aspect of our patient sign-up portal. We've done an event so far in Charleston, then a second one in Morgantown. We have an event coming up shortly in Beckley, and next up will be Logan after that. We were able to triple our turnout in the Morgantown event compared to our first one in Charleston, so we hope to see that increase in participation continue. Any questions from the members about the status of the Office of Medical Cannabis at this point?
Yeah, I've got a quick question. On that November timeline for products to be available, how many dispensaries do you think will be open at that time? Is it going to be a limited number, or are you projecting that all of the dispensaries will be open, or what's that looking like?
So, Rusty, a lot of that is a business decision up the industry. Certainly, we play a part in certifying the dispensaries as being operational. But I can certainly say that it will be a limited opening. There won't be enough products that first day to supply every dispensary in the state. And also, as I mentioned earlier, a lot of these companies and license holders are vertically integrated. And not every grower is going to have products ready mid-November. That's just the first one. We will continue to see more and more products be available as the industry matures, and of course their plants and products continue to grow and be built out. But it will be a limited opening. There's no way around that.
Thank you.
Jason, can you go over the medical cannabis card? Because remember we got some questions about how the card looks like, if it's printed, and then we got questions from law enforcement too, like how they can verify the card, if it's going to have like a scanner on it.
Sure. Sure. The card is an electronic card. The patients receive that by email link. The patients can then choose to print it themselves. So they have a hard copy, or they can show it on their smart device, be it a phone, tablet, whatever it may be at the dispensary when they show up there. It will have all the patient's information on there, any limitations placed by the certifying physician, such as limit on amount, form, or duration of medical cannabis the patient can receive. And there will also be a barcode on the card. The main purpose of that barcode is to pre-populate the patient's information into the dispensary system so they won't have to type it all in manually. But we're also looking at the law enforcement aspect of that barcode and how it may play a part in preventing any sort of fraud on the law enforcement end. Law enforcement could verify the validity of those cards. We've recently made contact with the State Police Intelligence Center. They became a good partner. We actually did a presentation for them yesterday on how this information can be disseminated to law enforcement. So we're looking at doing several in-services for various levels of law enforcement across the state as we go into this fall, and law enforcement will start seeing these cards in use by the public. We want them to be informed on what a real card looks like, how to verify it, and also how much medical cannabis a patient or caregiver can be in possession of. Our goal is to prevent any confusion and difficulty for both patients and law enforcement moving forwards in that process. And again, I think that information center that the state police runs, their purpose is basically to disseminate information to law enforcement across the state. I think they'll be a good partner in that process.
Jason, just I have one curiosity. about the demand of the medical cannabis in the state versus the supply, the production? What percent of the demand are we meeting within the state, and how much we are bringing from outside? Or is there any way, I mean, if we can expand the manufacturing here, can we go outside meeting our requirement? I mean, those are the few things.
Yep. So Dr. Khan, that's an easy question to answer. There are no outside products at all. All these products have to be manufactured and sold strictly within West Virginia. They can't ever cross the state border. To the other part of your question, will there be enough product for patients? I think based on the amount of patients we have right now, if anything, it'll be the other direction. There'll be an oversupply of products, maybe not at that first opening date, but as we move forwards throughout the rest of 2021 and into 2022, I think industry will be able to easily meet the demand for patient products in our state. We will continue to encourage potential patients that may benefit from medical cannabis to sign up for this program and try to match that patient demand to industry output. There's no specific square footage of canopy that industry has to produce in our state, so they're free to scale up or scale back their operation to meet the patient demand.
So this is only to meet our patient demand. There is no provision to go outside.
So there is. They cannot export their products. That would be interstate commerce. Cannabis is illegal federally. They absolutely cannot do that. And they also cannot import from another state. Again, strictly West Virginia grown products, processed products, and also retail products.
Okay, thank you.
Thank you.
Jason, a question. Do you happen to know what a ballpark figure of the potency of those 1,000 plants are, the THC potency?
So I do not, Mr. Deegan. We're not at the stage of testing those products yet. That will come at harvest. We will certainly know at that point exactly what the THC percentage is. And of course, that percentage will have to match the labeling of the product. But there is no limit on what that THC percentage can be based on our code.
So are you testing those in your facility or around the state?
So it'll be both. Right now we have one commercial lab that's ready to go. A second one that's investing in West Virginia and should be up and running shortly. And also, of course, we have our in-house lab that the Office of Laboratory Services has developed. Their purpose is to verify the commercial results that come in. But that commercial lab is ready and waiting for these samples to come in. We're just not to the point of sampling yet. We're getting close, though. Any other questions from the board members about the office and its progress? All right, thank you. Moving on.
Jason,
Okay,
I
so
apologize, Jason. I have one more question then about that.
yes, sir.
Besides the THC content, what else will be labeled on the product that'll be dispensed in November?
Yeah, so it'll have many aspects to the label, things like the form of medical cannabis within the container, the CBD content also. So there are many other lab tests that we're performing, such as heavy metals, mold, other contaminants. Those won't be on the label, but the main points of the label are THC content, CBD content by percentage, the amount of medical cannabis within the container, and also, of course, the form contained within that container. And of course, the patients have to retain those products within the original container. So law enforcement should be able to match up the contents with the container that would have came from one of our licensed dispensaries.
Thank you.
Thank you. So now, Dr. Amjad, we're to the point of work group updates for policy and program. Mr. Forbes is the chair for that work group. However, he is absent. Rusty has agreed to give us an update from that work group meeting.
The policy work group, we met on the 18th. We were joined by Dr. Libby Stutt, an addiction psychiatrist from Colorado, as well as a few members from the public. I think there were only 2. And we discussed the home grow proposal that we talked about at the last full board meeting. Just kind of talked about what the goal is, at least from my point of view, what my goal is with making this recommendation, with allowing patients to grow, solving some of the patient access issues. Dr. Stutt, she expressed her concerns with THC levels and not being able to monitor the THC levels in the plants that the patients are growing. She also was concerned with home grow basically causing more of an illegal market problem. So we had a pretty lengthy discussion on that. At the end of the meeting, we did not come up with any recommendations to bring to this full board. We did decide that there should be another meeting, another policy discussion to talk about home grow before the next meeting of the full board in December. I recommended that at this next work group meeting, we bring some patients in who, patients from other states to join the discussion, folks who are seeing the benefits from home grow. And I also think that we should invite some doctors from the state of West Virginia who are certified and part of this program to share some of the issues that they're having. But I was asked to put together a proper proposal for the next meeting in December, and I'm more than willing to do that. So that's basically where we are with the policy group. Again, there were no recommendations made and nothing to bring forth to the rest of the board. Joe Deegan was also there. Joe, if there's anything that you want to add to that, feel free in case I forgot something.
We talked about the concentration issue, and so I feel like we're getting some feedback, some input from other states, and that where there are concerns about the concentration, that there should be some level of limit on the concentration, and so I want to be able to bring that up as a discussion. My understanding was that the health and medical work group had already had that raised as a topic in their group, and they did not support bringing it forward. I just wanted to see whether or not that's something that, because I think there's going to be some other research that we need to do to make sure that we really understand what is going on with how marijuana is being cultivated now, and the potency of the THC in those plants, and the potential hazards and problems that are occurring in other states. So I'd like to, potentially open it up that we can revisit that as a topic for us to research, and possibly end up having some recommendations about that.
I don't believe that recommendation was made by Dr. Berry, and I don't believe it ever went to a work group. I think that the full board voted that down before it was sent to a work group. I think that's the way it went. Am I right on that, Jason?
I believe so, Rusty.
Are you sure? Because we did talk about it. If the way it worked was that we discussed it in the health work group, and unfortunately, we have not had robust participation in the health work group. There were only 3 of us, and at that point, it was voted down 1-2 or something like that. And that's when I brought it back to the larger group and said that it was voted down, so we weren't going to discuss it anymore. But I don't believe it was put before the larger group to take on as an issue to pursue further. It was just my recommendation based on the health working group.
Okay. Yeah.
When you made, it was my understanding that you made 3 recommendations at the same time, and 2 of them were sent to the work group, and that one was not. I could be wrong, but that's how I remember it.
That is my recollection also, that the full board didn't vote to have the work group further examine that recommendation. However, if the recommendation wants to be brought up, there wouldn't be anything preventing that from being brought back up.
I would obviously support bringing it back up and letting us really research this and trying to investigate, what does the data say? What have we learned, about this in the research and the problems that higher THC concentrations have caused? I think it would certainly be worth vetting further and letting all of us discuss it. So I am supportive of it, Joe.
Yeah. Well, I too would like us to do a little more, do some more research on that particular topic, because as I'm delving into this more and more, it seems like there are other repercussions that are occurring in other states, and we just don't have the research, don't have the data right now to really present to the full board for folks to actually vote on. So I'd like to be able to, go with the permission of the board to do that, and then bring back, that topic for discussion at a later point.
So I guess the question would be where to send this. Dr. Berry and I have had some discussions surrounding the difficulty of convening the health and medical group. Do any of the board members have a recommendation of potentially where to send that proposal?
I guess I would initially and cautiously, based on past experience, give us one more shot at trying to get participation in the health committee, because I do believe at the core this is a health issue. So I would ask the board to let the health committee take it up, but I don't have strong opinions about it.
So my recommendation, Dr. Berry, is that you would make a motion to take that action, if that's the way you want to go, and take a vote on it.
So moved.
Well, is that something for us to second? I'll second that if that's.
Yes. Yeah, that would be the action needed, Joe. So Dr. Amjad, we have a motion and a second to send this recommendation to the Health and Medical Work Group. Can we take just a verbal vote on that?
If everyone's in favor, how about if anyone's opposed to that? They can speak up, that'll be easier. You want to oppose to moving that?
I'm opposed to the recommendation in general, but if you want to send it to the work group for discussion, I guess that's all right.
And how about we send it to the work group and they can discuss it and then we'll bring it up? Does that sound? Can we do that, Jason, or does it have to still be voted on then since Rusty opposes?
Yeah, so it sounds like Rusty, we were taking a voice vote. He was the only one opposed to it in general, so it would already pass either way and go to the work group for further evaluation.
Okay.
So I think we're good to go there. Rusty, did you have anything further to add in your summary of the policy and program work group?
Not really to the board. I would like to say, if there are any patients out here watching the live stream and anyone, that's paying attention to this, we need your input. We need your participation. So when we're meeting and when we're having these work group discussions, if you've got someone in your family, someone you love, or you personally that's affected by this, we need your participation. I don't have anything to add as far as the work group breakdown, but I just think that we need to be hearing from patients, and I don't think we are. So yeah, if you're watching this, speak up.
All right. Thanks, Rusty. All right, Dr. Berry, we'll move on to the health and medical work group and your summary of activities.
Thank you. Yeah, like we already mentioned, we have not had, again, a lot of robust participation in the health work group, but we're still trying to work on that. It's just been difficult to get busy schedules arranged and put together. We were able to meet on August 24th, and Dr. Antolini was the other member besides myself who was able to participate. And then we also had Mike Goff, who directs the West Virginia Board of Pharmacy. And so the main issue that we were trying to vet was being able to somehow add dispensed cannabis to the West Virginia CSAP program, the database for reporting other controlled substances, and then adding this as an option to control as well. And so what Mr. Goff was able to let us know and inform us on was that there is a process in place for adding non-scheduled medications or even events such as overdoses to the CSAP report, where physicians and pharmacists, healthcare providers are able to access. Now, when it comes to medications, there's a number of data points that are usually collected and then put together through what's called a national drug code number, which is also attached to a prescriber's DEA number. So a number of these data points include, the patient's information, but then the type of drug, the amount, et cetera, et cetera. So the more we discuss this, it seemed like it would be the simplest way to go. The simplest process would make it a binary process, whereas opposed to the type, for instance, of cannabis dispense, it would just be, was cannabis dispensed to a patient or not? And if cannabis was dispensed, then that would show up on this report. So physicians who are treating these patients in the community would know that indeed they have been dispensed cannabis. And per Dr. Goff, that in itself is a relatively easy mechanism to set up through the vendor. And then it's just a matter of educating the dispensaries on how to do that, et cetera. The other issue that was considered that I felt was important from a physician standpoint is the ability to identify the certifier of the dispensed cannabis. So if there was an event or a concern by another provider, they would be able to contact the certifier and be able to discuss that with the certifier. And so in the same mechanism by which a dispenser would put in the dispensed cannabis, they should be able to also put in the name of the certifier on that report as well. It wouldn't be a prescription that the physician is writing or attached to, but it would be able to know who the certifier is. Mr. Goff was also going to look into what is done in Ohio, and maybe JJ would be able to give a little bit more insight in that as well. But he was going to look into more of those details about how it is actually done in Ohio, because they do have that on their reports. So we don't have a recommendation right now. It was more of just information as far as what we were able to learn, and would like to just investigate this further.
Dr. Berry, this is JJ. I'm not sure exactly how the information gets into the CSAP database, but it is product specific. So it would give the strengths, like a full description as far as full descriptions go. And it would show up when we search the patient's controlled substance history.
In Ohio, you're talking about.
In Ohio, yes.
So, Dr. Berry, as far as action items for your work group, it sounds like more discussions needed.
Yeah, we really didn't have enough people to put forth a recommendation, enough participants. So I suppose what I would recommend, if it's the will of the board, to just let us continue to vet this one as well, so we could come up. We would have enough participation next time to come up with a recommendation.
Yeah.
Dr. Annalini, if you have any other input on this as well, please feel free to speak up.
I don't have a whole lot to say as far as input. It was informative to see how we could integrate CSAP into medical decision making, as far as, you know, seeing patients, your regular patients that may be using medical cannabis. My fear and concern is more from the standpoint of people who are employed by federally qualified health centers and their involvement with providing the patients that we take care of with the resources necessary to get them access to this without actually being a part of that process, since we are federally funded. And my understanding is if we dabble too much in medical cannabis, that could put funding at risk. Is that, I think that we probably need some legal insight from that standpoint. And I've been still developing some thoughts on how that would look in the workflow of taking care of patients through an FQHC to ask this question. But it's starting to, I think we're getting enough momentum and making recommendations that I wanted to see how that issue fits in this larger picture.
I would, just as a recommendation, I would think that would be something that could be vetted through the policy subgroup to try to determine what are the legal ramifications of a federally qualified health center interacting with medical cannabis.
I agree. We'd have to look at that. Jason, have you heard anything about that? That's a good question, but I don't know. I can't talk. I don't know what the federally FQHCs have to do, but we can find out. Jason, do you know about that?
Yeah, I do not have any specific information on that. However, as mentioned, whenever there's federal funding involved, there is some concern there. But I do agree that the policy work group with the attorney members on that group may be the best place to explore any concerns. Dr. Berry, if you want that discussion to take place, again, I would just recommend making that motion and sending the discussion to that work group.
So moved.
Do we have a second on that motion?
Can I perfect the motion?
Yes, sir.
It just came to me, it wouldn't be limited to federally qualified health centers, but really any agency that affects that receives CMS funding.
Yeah.
So I
agree.
would perfect it to that.
Yeah, I would second that, because hospitals would be in the same condition, or even community mental health centers. Okay.
Yeah, correct.
I'll second that.
Okay.
Dr. Amjad, I would recommend just taking another verbal vote.
Is anyone opposed to moving that motion to the policy work group? No one's opposed to it, Jason, so yeah.
All right, great. We will send that over. Dr. Berry, anything else in your work group summary that you'd like to present?
That's it. Thank you, Jason.
Thank you, sir. All right, folks. I'll give just a second for any other questions. If we don't have any, we will move on to setting the next meeting date.
I do have one question. I'm involved with an association called the West Virginia Behavioral Health Provider Association, and they're seeking advice on from Department of Motor Vehicles related to how to handle situations with people that may be judged impaired, and then they demonstrate that they have a card that shows that they can access medical cannabis. Have you guys been asked to weigh in on that at all with the Department of Motor Vehicles?
So not with the DMV specifically, but that was part of our discussion yesterday with the WVSP Intelligence Center. There are some hard levels within the Medical Cannabis Act, but the difficulty is those are blood tests. They aren't necessarily easily translatable to the field. So that's going to be some further discussion that we'll definitely have with law enforcement and try to come up with a solution to not only impaired drivers, but impairment in other aspects of life, whether it be workplace or something else that could create danger. So we are definitely exploring the issue.
Okay, thank you.
And I've got a question. I'm not sure if this is the appropriate time, but at some point, I do think this board needs to take action on a recommendation, a reciprocity recommendation. Like when you were talking about the dispensaries will open on a limited basis in November. There'll be a lot of folks here that won't be able to access their medicine. And I think that if we could recommend some language to the legislature that not only allows West Virginia patients to visit one of our border states to access medicine, but also allows patients with medical cannabis cards from any of the 33 medical states to come here and buy product in West Virginia. I'm not sure what that what the motion would look like, but at some point I do think that we need to seriously look at reciprocity. If that's something that needs to be sent to a work group, fine with that. If you think that it's something that's, and it's a pretty simple issue. Maybe it just comes up for the full board without going to a work group. I'm not sure the best way to go about that. So what are your thoughts on it? Like, what's the best way to make that happen?
So Rusty, from the office's perspective, we have a pretty clear directive by code as far as reciprocity is concerned. It's only available to terminally ill patients. I would leave it up to the board's prerogative to decide what action they would want to take, if any, as far as reciprocity is concerned. It's the board's prerogative to make the recommendations they feel are appropriate to the legislature. But again, as far as operationally, the office can't do anything more than what the law says currently, and it's specific as far as reciprocity is concerned.
Well, if this is the appropriate time, can I move now to bring the issue of reciprocity up for discussion by the full board?
Yes, sir. I believe you can move to take any action you feel appropriate.
Okay, so moved.
Do I have a second to discuss reciprocity before the full board? Dr. Amjad, I'm not hearing a second for Rusty's motion.
All right. Hope patients are paying attention to the actions of this board.
Okay. All right. Thanks, Rusty. Any further items that members want to discuss? Okay, we have several action items to move back to the work groups. We will certainly facilitate that from the office side of things. Next point of business is to set a date for the next meeting. One little bit of information I want to touch on with that. There was a request from a couple different members to add an in-person aspect to this meeting. We did explore that. Was able to identify a good location that already has the hardware necessary to integrate in-person and virtual meetings at the Capitol complex. However, after some discussion internally, it was deemed not wise to incorporate that for this meeting due to the trajectory of the pandemic. Do the members want to explore that in-person aspect for the potential December meeting, or do you want to continue on with virtual? Dr. Amjad, maybe you have some insight into this.
I think we plan on virtual because of the winter time, and we don't know what's going to happen. I do believe a lot of people live out of the Charleston area, Jason, so I think it's safer to plan on that. I mean, we can always pivot and change at shorter notice, but that would be my sentiment. I'm happy to hear from the rest of the group though what they would feel like doing.
I believe that would be wisest.
Okay. Any further discussion on that subject? Okay. So sticking with our typical schedule, my recommended date would be December 16th. If you go any further than that, you're going to be into the holidays, and that would be the typical Thursday, and again, noon to 1:30. Are the members okay with that proposed date and time? Anyone that doesn't like that date? Okay. We'll go with December 16th, noon to 1:30, virtual. Any other topics, specific topics beyond what's already been sent to the work groups that members want to put on the agenda for that next December meeting?
Jason, I would like to add, because I think we still get questions about, you know, how we're adding the time, the 2 years and the cost of the fees and things like that. I think some people might want to just get some updates. We have people listening in and things like that. And so we talked about it a couple of meetings ago, but maybe just to give some updates with that and about our website. I don't know. I know we were working on updating our website.
Sure. So as far as the bonus timing, I'm sorry, Dr. Amjad, did you want me to cover this right now?
We can right now, but and then even later, because I don't know how many people come on and off and things like that. But.
Okay. Well, real quick with the bonus time for the cards, as previously discussed, we implemented that bonus time to encourage folks to be early adopters instead of waiting until the dispensaries are open and anticipate a rush of patients when that happens. The first deadline for the larger amount of bonus time has already passed. That was June 30th for an additional 2 years of the card being valid. There's still bonus time available if patients can sign up by the end of this month, September 30th. They'll get an additional year of valid time on their card. However, it is important to note that they'll still have to visit their registering physician or certifying physician during that time period. The bonus time only applies to the card itself at the state level being valid. It's very important the patient continues to follow their physician's recommendations that may be applicable, such as follow-up visits. And I apologize, Dr. Amjad, what was the second point that you wanted me to cover?
Just where they can find more information on our websites for like our meetings and any other information, but we can cover that next time. I think it's just for, you know, not just for our group, but even if people are watching.
Sure, absolutely. We do have our existing website, www.medcan, is in medicalcannabis.org. We have all the information for our office on that website. It has been recently redesigned. We do continue to add more information to that website. However, that is really the clearinghouse for any information the public or interested parties may need, and also, of course, links to the patient registration system.
Thanks, Jason.
Thank you. So, Dr. Amjad, I believe the last part of this meeting would be to take public comment, if there is any. Looking down the list here to see if we have any members. It looks like Kevin was a member of the public. If the members are open to it, I'd like to give the floor to Mr. Waugh to comment.
All right, good afternoon. Thank you guys for your time. I have a question about the CSAP program. Dispensaries are required to record all medical cannabis to OMC for every patient to keep track of the monthly allotments and stuff. Couldn't the physician, if he just wanted to see if his patient is using medical cannabis, just sign some kind of HIPAA form or something and get a hold of the OMC to see, you know, if he's taking medical cannabis and, you know, the allotment and stuff like that, instead of recording it through the West Virginia CSAP program? Thank you.
So just to quickly address that, I believe the process Mr. Waugh referred to is why the recommendation for CSAP reporting has been made, so the physician would have easy access to that information. Right now, there's not a process for OMC to give out that information to a third-party physician. Dr. Barry, do you have anything to add to that?
You've got it right, Jason. It's basically there's already a process that exists by which physicians now are habituated to use this database. It's become part of our practice, and that would be the logical place to put it. In trying to create a second mechanism will create a whole bunch of extra steps that would make it both difficult, cumbersome, and then also have some legality issues that would probably make it not possible.
Thank you. It looks like we do have a couple more members of the public. I want to move on to Jeremy Husted.
Yeah, that's my name. Thank you. My name is Dr. Jeremy Husted. I work at WVU Medicine. I'm also the president of the West Virginia Society of Addiction Medicine. So a couple comments. I fully support the idea of having any cannabis that's dispensed be part of CSAP. So that way physicians, if something were to happen, they knew who's prescribing it to whom. If we're going to consider cannabis to be medicine, we should treat it like medicine and have the same rules that apply to any other controlled substance. So I can't imagine a situation where I would be able to prescribe Xanax or Klonopin or whatever, and a doctor is not able to see that it's me prescribing it. That would be wholly ridiculous. The other thing is I would just strongly encourage the board to very closely look at THC limits, which is something that Europe especially is looking closely at. The idea is, even including in the Netherlands, where they've had a lot more experience with cannabis than us, there are a lot of concerns about potency, to the point that they're considering anything above 15% a hard drug on line with methamphetamines and heroin. So I would just strongly encourage to learn from others' mistakes, people that have actual experience with it much longer than we have. And lastly, I would just strongly encourage us to consider what addiction experts are saying, because in the past, we kind of sent out the red flags when it came to opioids and were largely ignored back in the 90s. So I would just encourage you to especially take what we have to say into consideration when you're making your determinations. Thank you.
Thank you, sir. And finally, it looks like we have Sherman Home.
Well, hi. Thank you very much for this opportunity to make a public comment. Yeah, my name is Dr. Sherman Hom, and I recently retired from the New Jersey Department of Health, Public Health and Environmental Laboratories after 20 years. And 9 years ago, I was the project manager that started the first cannabis testing lab in New Jersey. And then I put together a compendium of all the required testing in every state medical cannabis program in the country and maintained it up to 2020. And then I was the subject matter expert for required microbial testing in New Jersey. And I recently joined Medicinal Genomics Corporation as their director of regulatory affairs. And I would like to just note that a heads up that I'll be sending our recommendations for possible modification of your required microbial testing of your medical cannabis, hopefully by the end of this week. And I do have one question, if you're able to answer this. I don't know if you can in public comment period, is that I have reviewed your regulations and I don't see any action limits for the listed microbial tests that you have. Thank you very much.
So just to address that concern, Dr. Holm, those limits have been set and they are within the reporting system that industry uses to input lab results. And finally, it looks like we have Dr. Stout on here now also. Dr. Stout, feel free to go forward with your comments.
Okay, thank you. I'm trying to, yeah. Thank you very much for letting me speak. I just wanted to support some of the stuff that is going on. I really appreciate the fact that you're really looking at this seriously. I'm an addiction psychiatrist in Colorado, and we've just gone about it in the wrong way in Colorado. I do support using medical marijuana for patients that need it, but I do want to point out that the studies that have been done to support the use of cannabis for any medical condition have been done with less than 10% THC in the smoked plant. And, you know, in the other studies that have used isolated THC concentrations, the limit has been like as much as 130 milligrams a day. And so I think it's really important to look at your potency, because in Colorado, we are seeing so many problems, to the fact that we actually had a law passed this past year to start putting more strict regulations on our concentrates, so the higher potency products. And part of that is putting it on a system like your CSAP, because that, as a physician, I have had so many problems with, I would find people that had a medical card and were having terrible issues as a result. And I wanted to talk to the person who was recommending it, but they couldn't remember who they were because they only saw them one time. They didn't have a card that said their name. And so I couldn't really discuss it with another physician to let them know my concerns that I was seeing, because I was seeing a lot of people with psychotic symptoms, with suicidal ideation, with cannabis hyperemesis syndrome. These are all things that are happening with the higher potency products. So I just encourage you to really take that seriously and look at it. Thank you.
Thank you. Any further public commenters, please virtually raise your hand at this time. All right. I just want to remind the public that may watch this at a later date. You're certainly welcome to send in written public comment also. Email that to medcanwv@wv.gov with MCAB public comment in the subject line, and we will forward that that comment to the board members. All right, Dr. Amjad, that wraps it up from my end. Unless any other board members have anything to discuss, I would recommend closing the meeting at this time.
Need a motion to do that then?
Yes.
Moved.
Okay. Second is then. All right. Thanks everyone. Thanks for joining and all the comments as well. Thanks, Jason.